Welcome back, and we're continuing with disorders of the immune system, and we're going to start talking about hypersensitivity reactions. And these are, in a normal person, we know that the immune reactions do their job without hurting the host. But unfortunately, sometimes immune reactions can be excessive, and then that results in disease for the host. And people who mount normal immune responses are sensitized to that antigen, but people with excess response become hypersensitive to that antigen. And so we're going to talk about what all that means as we go along. So what happens in these reactions is that for the person, when they have some kind of antigen, their immune response is triggered, and it's triggered inappropriately. And unfortunately, it's really hard to eliminate the stimulus because the immune system has been fooled into thinking that whatever this is bad for the person, and that's not necessarily true. Now, the cool thing would be is if we can genetically figure out through the study of the human genome how to calm the immune system down and allow it not to be hyper responsive. So this hypersensitivity, it results in basically things that are chronic or even diseases that can be very debilitating and potentially even cause death in your patient. So hypersensitivity reactions come in 4 types. So type 1 is what they call an immediate hypersensitivity, and we're going to go through all of these in detail, and can create an anaphylactic reaction. So it's very much like allergies, okay? And we can have an allergic reaction, and so we'll talk about how that all occurs. Type 2 is what we call a cytotoxic reaction. This is antibody dependent. Type 3 is what's immune complex reaction. Type 4 is called a cell-mediated or delayed hypersensitivity reaction. So KERRY is a 40-year-old airline pilot and has made an appointment with her primary care physician to discuss a rash that develops whenever she spends time in the sun. As she explains to her physician, it does not seem like sunburn. She's careful not to spend too much time in the sun, and she uses sunscreen. Despite these precautions, the rash still appears, manifesting as red, raised patches that get slightly scaly. The rash persists for 7 to 10 days each time, and it seems to largely go away on its own. Lately, the rash has also begun to appear on her cheeks and above her eyes on either side of her forehead. Is KERRY right to be concerned, or should she simply be more careful about sun exposure? Are there conditions that might be brought on by sun exposure that KERRY's physician should be considering? So we're going to go through these hypersensitivity reactions, and you can see if you can answer those questions. So hypersensitivity type 1 is going to involve immunoglobulin E antibodies against antigens, okay? And the big deal is this is going to trigger mast cell degranulation, which we talked about in the previous video, bringing on things like histamine. Type 2 hypersensitivity involves IgG and IgM antibodies, and they're directed at certain cellular antigens, which we'll talk about. And of course, this can cause damage by our own immune system. Type 3 hypersensitivity reactions are IgG, IgM, and sometimes IgA antibodies. And these form immune complexes. And so we'll talk about what that means to our system. And then type 4 hypersensitivity reactions are T-cell mediated, and they can involve tissue damage, and it can activate macrophage and cytotoxic T cells. All right, so type 1 hypersensitivity. So what happens is a person is pre-sensitized when they're exposed to a certain allergen. And this leads to an immune response. And of course, we call this an allergy. And allergens can be anything from food that we eat, and it can be animal dander, molds, It could be something a little bit more toxic, like insect venom, or we could even be allergic to certain types of drugs, like people have allergies to penicillin. So the first exposure you have to this allergen activates the immune system to produce IgE antibodies. And this sensitizes the individual to this allergen. And so this is why we call this a type 1 hypersensitivity. And they're more sensitive if they're exposed a second time. So quite often, if you're exposed to an allergen and your body's going to be allergic to it, you might not have very much of a response the first time, but the second time it could be a really bad response. Like, for instance, my daughter was stung by a bee when she was 5 years old, and we knew there was an issue because she was stung on her thumb and it had swollen up like 5 times its normal size. And so, of course, what the doctor said is that this is going to be a hypersensitivity for her, and now she has to walk around with an EpiPen because of the potential reaction now that she's been sensitized to this. So sometimes the type 1 hypersensitivity is also known as an immediate hypersensitivity. So again, on first exposure, your antigens are presented to B cells and T cells, and we make those IgE antibodies, and they bind to the mast cells. Now, mast cells are now primed so that when they're exposed a second time, this is when they're going to degranulate. And mast cells are going to release histamines and stimulate bradykinins and serotonin release. And all of these chemicals are going to affect, for instance, blood vessels. And we talked about in the last video what histamine can do. But serotonin and bradykinins can also cause more blood vessels to vasodilate and smooth muscle to contract, and you can have this massive, potentially inflammatory response. And so one of the things that happens is if you get enough of this histamine, bradykinin, serotonin floating throughout the system all at once, you have so many blood vessels vasodilating that blood pressure can drop. And if blood pressure drops too much, this is dangerous. So this is just a picture of a normal mast cell, and then you can see the mast cell here degranulating. So what do mast cells release upon second exposure? Histamine is the big one, but we also talked about serotonin and bradykinins. Heparin is going to be stimulating bradykinin release, okay? And one of the other things is that also leads to low blood pressure is increased vascular permeability. So that is all those fenestrations that can occur. And of course, the whole idea is to allow those macrophages to get into the tissues, because the immune system still thinks that there's something that it needs to be responding to, some kind of virus or bacteria, when really it's not that at all. Oops, sorry, wrong way. When you have a second exposure, the mast cells can then release even more chemicals. So we have chemicals like leukotrienes, prostaglandins, and TNF-alpha, which stands for tumor necrosis factor. And so leukotrienes can cause smooth muscle contraction and increase vascular permeability again. Prostaglandins are going to help with that vasodilation. And then tumor necrosis factor is a cytokine. So it can actually stimulate the specific immune response and also create inflammation. So this is just a flow chart showing you how the leukotrienes and the prostaglandins, which the PGD2 and the PGE2, these are prostaglandins. So this is a flow chart showing you when things are stimulated that we release from the cell membrane arachidonic acid, and then these enzymes convert arachidonic acid into prostacyclin, thromboxane A2, which can promote platelet aggregates and coagulation. Prostacyclin is helping with vasodilation, and then the prostaglandins with vasodilation also. The leukotrienes increase vascular permeability. And then here's the other thing too, is you can have bronchospasms. So that is one of the side effects with a really bad allergic reaction. So some of the things that could cause us to be hypersensitive, like I said, would be the bee stings or food allergies, asthma, hay fever. So we've talked about this, the vasodilation, vascular leakage, smooth muscle spasms, and that's an immediate response, happens within minutes, but then you can go on to have more release of these cytokines, which creates increased inflammation and then eventually tissue destruction. So some of the reactions that a patient might have would just simply be like local dilation underneath the skin, so that would create hives, potential itching, but we could also have that bronchospasm or bronchoconstriction. It could lead to diarrhea, and then that, by the way, the diarrhea is from all of the smooth muscle contracting, and it actually makes peristalsis in the gastrointestinal tract go faster. The big deal would be anaphylaxis. So this is too much histamine along with all those other chemicals being released, and you get massive vascular leakage and vasodilation, and then you get the erythema, that is redness of the skin, and that can also be an indication of this anaphylaxis, and then your patient has decreased blood pressure, goes into shock, and potentially could die. So these are just showing some hives. One of the things about hives is if you were to take your two thumbs and press it against the skin on either side of the hive and then pull, the hive should disappear. And the reason for that is because that's localized swelling. So it's probably a pretty good indication that whatever you're looking at is a hive. If that doesn't occur, it's probably not a hive. And then the swelling can be anywhere. So what happens to your patient? Again, this is just another chart so that you can take a look at that. You can look at that a little bit later if you'd like. Hypersensitivity Type II reactions. Okay, so this is an immune reaction, okay, which could also be considered a cytotoxic hypersensitivity. And again, this is IgG and IgM antibodies, and they're binding to cell surface antigens. And these antibodies can activate complement, or they can activate cytotoxic T cells. And so what happens is you have the inflammatory response, and then potentially you have lysis of whatever cell that the complement or the cytotoxic T cells are targeting. And of course, we talked about all of this in the previous video. So it can be involved in what we call antibody-dependent cell-mediated cytotoxicity, which basically means that an antibody can bind to a cell, and then the cytotoxic T cell is able to basically locate that cell and bind to it and destroy that cell. These are just some of the potential diseases that can occur from type 2 hypersensitivity. So we'll talk about a lot of these as we go along, but for instance, pernicious anemia. This is kind of an interesting one. So you know about parietal cells. And parietal cells, they secrete hydrochloric acid in the stomach for digestion, but they also secrete what's referred to as intrinsic factor. Now, intrinsic factor is something that is needed in order for us to absorb vitamin B12. And if you don't have enough vitamin B12, you can't make enough red blood cells, and then you have anemia. Now, pernicious anemia is a type of autoimmune disease. So what that means is your body is destroying the parietal cells, and there aren't enough parietal cells, and so you can't make the intrinsic factor. Now, why your body is destroying those parietal cells is probably because the antigen that the cytotoxic T cells are responding to is the person's own MHC, and that MHC has somehow either been altered or the immune system no longer recognizes that MHC and therefore attacks those cells. Another type of problem would be, for instance, Myasthenia Gravis. And this is where the immune system is going to create antibodies that are binding to acetylcholine receptors. So if you remember in our skeletal muscle, we have acetylcholine that's released from the motor neuron, and then that acetylcholine is going to bind to the membrane of our skeletal muscle. Now it has to bind to those receptors on the membrane, but what happens is our body produces these antibodies that destroy those acetylcholine receptors. And now there's no place for acetylcholine to bind, and you can't stimulate skeletal muscle, so you have muscle weakness. So with the cytotoxic hypersensitivity, you can have what's called a direct action, and this is where the antibody attaches directly to an antigen on the cell membrane, and that again, IgG or IgM antibodies, okay? Or you have an antibody-mediated hypersensitivity, and again, the antibody binds to the cell surface, and this time macrophage come in and they eat up the cell that has the antibody bound to it. In the last one, I forgot to mention that with this direct one, the cytotoxic T cells come in and they destroy the cell that the antibody has bound to. So the end result is the cell dies, and inflammation can also occur. So antibodies bind to the cell surface. One of three things can happen. So opsonization, again, that means that this antibody is going to make it easier for the phagocyte to bind to the cell to destroy that cell. Excuse me. Inflammation can ensue from this. Or what happens is the cell isn't able to function appropriately. And we'll talk about this a little bit. With Graves' disease, for instance, our body secretes an antibody that mimics TSH. So TSH, if you remember, is thyroid stimulating hormone. And so this antibody can bind to the thyroid gland, and that fake TSH antibody is able to stimulate the thyroid gland to produce more T3 and T4 than usual, and then that means that metabolism is going to go up higher than it's supposed to. So this is just showing opsonization, where you have these antibodies on the outside of the cell, and that lets the phagocyte bind so that phagocytosis of this poor cell, this bad cell, can occur. Or these antibodies can also allow complement to bind, and then you get direct lysis of the cell. So with inflammation, what happens is the antibodies can bind to the cell membrane, and then what happens is either complement can come along, or the antibodies actually bring in the mast cells and release of histamines, and you get the inflammatory response. An indirect type of type 2 hypersensitivity is where you use the IgG antibodies, and they target the cell membrane receptors and they block receptor function. And so this is what we were talking about with the Myasthenia Gravis. So you can see here, this is a picture also of Graves' disease. So these are the TSH-like antibodies that are going to bind to the thyroid and increase thyroid hormone stimulation. Or here is the motor neuron releasing acetylcholine, and then that acetylcholine is supposed to bind to these receptors. Well, the antibody is attached to the receptors and won't allow acetylcholine to bind. And over time, those receptors can be destroyed. They actually are phagocytized. And same thing you see here. This is a normal motor neuron releasing acetylcholine, binding to the cholinergic receptors on the skeletal muscle, but here they can't bind because the antibody is attached. And this is just a picture showing you some of the effects of myasthenia gravis. So you can see the normal eyelid here. This is an eyelid that is more flaccid and drooping. So we talked about Graves' disease. Another one is Erythorblastosis Fetalis, and then we also have hemolytic transfusion reactions. Okay, so this talks a little bit more about that. You can look at that. But those hemolytic transfusion reactions, if you remember, you have certain types of antigens on the outside of red blood cells. So you have antigens that show you that you're type A or type B, or you might have both of those, so you're a type AB. Now, if you were to have a person who is a donor and they're type A, and they donate their blood to somebody who is type B, what happens is the immune system doesn't recognize these type A receptors. So the immune system is going to create antibodies that are going to then bind to the type A receptors and grab a hold of all these red blood cells and actually cause them to bundle together, or what we call agglutinate. And those red blood cells create big blood clots in the system. And so this is not a good thing. You don't want the immune system reacting, so you have to make sure that you give the individual the correct type of blood. Erythorblastosis Fetalis, now this is where the immune system is not reacting to type A or type B blood, but is actually reacting to the Rh receptors in the blood. So if you can imagine, mom, she's Rh negative. That means she doesn't have any of those Rh receptors on her red blood cells, but baby is Rh positive. Now, there is a barrier between mom's immune system and baby's immune system while mom is pregnant. But when mom delivers, a little bit of mom's blood and a little bit of baby's blood at delivery do mix. Now, prior to delivery, there's no mixing of the blood. And mom's immune system, when it sees the Rh, it doesn't really know what to do with it because it's never experienced it before. However, when mom gets pregnant a second time, her immune system goes, oh yeah, I remember that Rh thing, it's bad, it's not supposed to be here. And her immune system actually figures out how to overcome the barriers, and her immune system goes into baby. Now, what happens is her immune system secretes antibodies against baby's blood. And so now you're going to get this same agglutination effect. And throughout baby's entire bloodstream, there's going to be blood clots everywhere. So you know that they have the RhoGAM shot, and they give that to mom right after she delivers that first baby. And then they give her that RhoGAM shot when she's pregnant the second time, a couple of times throughout pregnancy, and then after she delivers, they'll give her that RhoGAM shot again. And that RhoGAM shot, what it does is it prevents her immune system from remembering that Rh factor and being able to secrete those antibodies with the second or the third or whatever pregnancy. All right, so we're back to KERRY again. KERRY's primary care physician is not sure why KERRY seemed to develop rashes after spending time in the sun, so she orders a urinalysis and basic blood tests. The results reveal that KERRY has proteinuria, or an abnormal protein level in the urine, hemoglobinuria, excess hemoglobin in the urine, and a low hematocrit, or red blood cell count. These tests suggest that KERRY is suffering from a mild bout of hemolytic anemia. The physician suspects that the problem might be autoimmune, so she refers KERRY to a rheumatologist for additional testing and diagnosis. Rheumatologists specialize in musculoskeletal diseases such as arthritis, osteoporosis, and joint pain. Why might KERRY's physician refer her to this particular type of specialist even though she's exhibiting none of these symptoms? All right, so we'll continue with KERRY in a little bit. All right, so mechanisms of autoimmune diseases. So sometimes autoimmune diseases are hereditary, and that means that for an individual, something is going on with the genes that help to control the immune system, and especially the genes on chromosome 6, which help to control the MHC. Many autoimmune diseases are gender specific, and unfortunately, I hate to say this, ladies, but we are more prone to autoimmune diseases on the whole than men. So the autoimmune disease, like we talked about before, is a failure of self-tolerance, which simply means our immune system no longer is able to recognize certain things as self versus non-self. So certain HLA types seem to inherit certain autoimmune diseases. So remember we talked about HLA A, B, and C, and then we talked about DP, DQ, DR, and certain types of those HLAs are going to be much more likely to have autoimmune diseases. So, for instance, 90% of patients with an autoimmune disease called Ankylosing spondylitis have an HLA-B27 antigen. So that means that this person's DNA produces this protein that's on the outside of their cell. Only 7% without the disease have this antigen. Okay, so it's a pretty good indicator of getting this type of disease. So this may be the trigger that causes the immune system to not recognize this antigen anymore. And so I shouldn't say this may be the trigger. Let me back up a second. So the interesting thing about autoimmune diseases is that there is typically an event that triggers the immune system to not like this antigen. So for instance, I may have this antigen on the outside of my cell right now, and my immune system seems just fine and dandy, and it's not doing anything about it. But then I have some kind of trigger event. And quite often that trigger event is a stress event. Now, not a little stress. We're talking either big stress for long periods of time, or you have one massive stress. Something happens in that stress event, and we know stress has a lot of cortisol involved. Cortisol can change our DNA. It seems to potentially activate things that now say to our immune system, hey, you don't like this antigen. You need to do something about destroying this antigen. And again, the question is, once stress turns on this autoimmune response, is there a way we could go in and turn that back off? And right now the answer is, who knows? So this is ankylosing spondylitis, a severe vertebral arthritis, and it's associated with inflammatory bowel disease and psoriasis in the patient. Now, one of the things you can see with this patient is they start bending over, and they bend over eventually so much that it actually compresses on the gastrointestinal system, and that creates a lot of difficulties for the patient. Eventually the vertebrae can fuse, and they may not even be able to lift their head anymore. Effects, now this time it affects men more often than women. Rheumatoid arthritis is an autoimmune disease, and this is affecting the synovium that lines our joints. And a lot of times, and this is with more than rheumatoid arthritis, a lot of autoimmune diseases start with low-grade fevers, and they start with kind of just malaise, like the person just there's just something wrong. I just don't feel good. And then they have joint pain. And with rheumatoid arthritis, the joint pain is worse early in the morning, and as the person starts to move around, the joint pain and the stiffness isn't so bad. With other autoimmune diseases, the joint pain may stay the same all day long no matter what. Okay, so now you can detect what we call rheumatoid factor in the blood, but this is a type of antibody that's being produced. And again, these people have the antigen on the outside of the cell coming from HLA-B27 gene. And so you can see what happens with this disease is it eventually erodes the joint and allows for things to go far out of place. That's very painful for your patient, and then of course they're not able to use certain parts of their body or certain limbs. Scleroderma, or sometimes called systemic sclerosis, this is a connective tissue autoimmune disease, and this is where collagen just goes crazy, and you start depositing collagen in the skin. The worst part is it's also deposited in internal organs, places where collagen has no right to be. For instance, you can get scleroderma where collagen is being deposited throughout the lungs. And there's so much collagen in the lungs, you can't breathe anymore. And so people sometimes have to have a double lung transplant because of scleroderma. This is where you can detect what they call the Scleroderma 70 antibodies that are being produced. And these antibodies, as they're being produced, are causing collagen to be deposited. And so according, of course, other places like blood vessels, kidneys, heart, GI tract. So one of the things you see when you have excess collagen in the skin is that the skin becomes very shiny and very tight. And it's not that the joint here is bad, it's just that the skin is so tight, it's pulling on those joints. And this is extra collagen underneath the tongue so that the person has a hard time lifting the tongue, they have a hard time chewing and talking, and that collagen has to be cut and removed, and it's quite often that it has to be done. Another type of autoimmune disease is Raynaud's, and Raynaud's is where blood vessels spasm, and those blood vessels can spasm anywhere in the body. And usually what happens is, remember, blood is carrying heat. And if those blood vessels spasm, wherever there's a decrease in blood flow, you're going to see that the area is going to be very cold. And so that can lead to pain and numbness. Okay? And so you can see that's a pretty good case of Raynaud's, where the blood vessels are okay in these fingers in this part of the palm, but they've spasmed all of a sudden in this part. And initially it can turn white, but if there's not enough blood flow for long periods of time, it can actually start to turn black and you can have necrosis. And by the way, that for your patient is quite painful as well. Hypersensitivity type 3, okay, also called immune complex hypersensitivity. So in a normal response, you produce antibodies, but in this type, you're going to produce excess antibodies, which are primarily IgG, okay? Even though there's a very low concentration of an antigen in the system, and you are going to get those immune complexes that I talked about before, so that agglutination occurs. And these can be deposited on the surface of epithelial tissue, in small blood vessels, especially the inner lining of the small blood vessels, or even on the surface of other tissues. So these immune complexes, they're going to accumulate, and then they can create an inflammatory response. So these inflammatory events, the IgG is binding to the antibodies, or the antibody receptors on mast cells, and the mast cells degranulate. And of course you get the histamine and the leukotrienes. And then complement can also be activated for pro-inflammatory response. By the way, C3a and C5a, these are some of the complement proteins. And increased blood vessel permeability, increased blood vessel vasodilation, and then you see neutrophils and macrophage coming to that site. So immune complexes, one of the things is that they're too big. So you have all these immune antibodies and cells coming together. There's too much of them, and because of that, phagocytes can't eat them and destroy them. So the phagocytes they're kind of like, I don't really know what to do anymore. So a lot of times what will happen is they will degranulate, and when they do, they release lysosomal enzymes. And these enzymes will cause damage in the tissues where they're being released. Okay? It can also activate coagulation pathways so that you have an increase in blood clots, and of course that leads to necrosis. So this is just a picture showing you the immune complexes that can occur, and these complexes can get onto the surface of epithelial tissue or the surface of blood vessels and create issues. And this person is going through a process where those immune complexes are actually filtered out of the bloodstream. So types of diseases that would be type 3 hypersensitivity, one would be like lupus, systemic lupus erythematosus. And the interesting thing about lupus is that we secrete multiple different types of antibodies that will then attack multiple different areas of the cell. So for instance, one type of antibody is a nuclear antibody. And so this antibody actually goes into the nucleus of pretty much any cell in our whole system, and that antibody creates complexes, and eventually the cell is destroyed because of those complexes. So it could be in the skin, it could be in joints, it could be in the kidneys, and it just really is anywhere throughout the body. We're going to talk about polyarteritis nodosa and serum sickness and arthritis reaction as we go along. So polyarteritis nodosa is a inflammation of blood vessels, or what is very often called systemic vasculitis. And about a third of these are caused by hepatitis B infections, and they're associated with inflammation of the vascular wall due to immune complexes. So this type 3 hypersensitivity. You also have what are called inflammatory myopathies, and this is an autoimmune skeletal muscle injury. And this can occur in multiple different types of autoimmune diseases like lupus and rheumatoid arthritis. And again, these complexes are breaking down skeletal muscle. And this gives you muscle weakness, fatigue. Some of these diseases, the myopathies are so bad that skeletal muscle breaks down so much that the individual can't even lift their arms higher than their shoulders. So this is a picture of polyarteritis nodosa, and what happens is you see these erythemas, or this redness. It kind of looks brown in this picture, but there's a lot of redness throughout the skin, and that's from the blood vessels. And by the way, these blood vessels are breaking down. There's a higher risk of a thrombus also developing in these, and so this is potentially very dangerous for the patient. So two kinds of type 3 hypersensitivity reactions. There's the systemic immune complex disease, where those complexes are formed in the circulation and then deposited in different organs. And this can be something like what we call serum sickness. And then there's a local immune complex disease, where the complexes are formed right at the site of an antigen on the surface of a cell, or on the site of an antigen that you have some kind of injection that might occur. Okay? And so this is what's called an arthritis reaction. Now, it's interesting because an arthritis reaction is probably one of the first things that was ever discovered for hypersensitivity types of reactions, and Dr. Arthritis is the one who actually discovered this. And so we'll talk about this a little bit more. So this is a localized immune complex reaction, and this is the arthritis reaction. And so what happens is you have something going on, like for instance, they had a TB test, and now you have a reaction to this. And for this one, that's a hyper reaction, but it could also be like if you had an injection of, I don't know, penicillin or something that occurred. The injection at the site created all of these immune complexes to come to this area, and now you're getting necrosis of the tissues and vasodilation of the blood vessels and an inflammatory response. Serum sickness. Now, this is interesting because in the old days we used to use horse serum for immunizations, and we don't do that any longer. But that horse serum, for many people, what would happen is they would form these antibody complexes, and they would get this type of sickness where the antibody complexes would move through the body and get into joints and blood vessels, kidneys, different places like that. And then you had this massive inflammatory response, joint pain, proteinuria. You might see rashes or hives, which is called urticaria, and then swelling, fever. Now, the way to stop this would be corticosteroids, and then, of course, if it's possible, to remove that allergen. So no more of those types of shots ever again. And this would be serum sickness. Doesn't look like a lot of fun. Okay, so lupus. So lupus is a chronic inflammatory disease, and it hits many different systems of the body, like we said, the kidneys, the joints. You can have rashes on the skin, mucous membranes. It is where multiple antibodies are formed, what we call autoantibodies, and they're attacking self. And they can also form complement and other clotting factors. They can attack platelets, red blood cells, lymphocytes, and then it can also attack things inside the cell like ribosomes and microtubules, lysosomes, RNA, even nuclear DNA. And there are just some examples, again, of what it could attack. Now, the other thing about lupus is interesting because you could have an autoimmune lupus, or you could actually have a drug-induced lupus. So some people have lupus-like reactions, and they even make these autoantibodies that are attacking their system and can be measured by blood work, but it's all because of a certain medication that they're taking. And if you stop that medication, they don't have lupus anymore. So some of the symptoms of lupus, and a really big one, is a butterfly rash. And that rash I'll show you some pictures of, but it goes across the surface of the skin. There is another type of lupus that's called discoid lupus, and you get these little tiny disc rashes. And again, I'll show you that. And usually those disc rashes are due to sun exposure. Mouth sores, this is a typical one, or sometimes sores in the nose. Arthritis. They can have inflation of the pericardium, which surrounds the heart, or they can have pleurisy. Kidney problems, that's a really big one, and neurological problems like seizures, strokes, mental health issues. And then, of course, they have abnormal blood tests because we talked about they have problems with platelets, but they could also have problems with red blood cells, problems with white blood cells. Now, it's really difficult to diagnose lupus because it seems like the antibodies for lupus are kind of slow coming for a person. So lupus develops typically very slowly. The person has odd symptoms. They might complain about joint pain, or I'm really super tired all the time. I just don't feel good. And it might be years before they ever have a butterfly rash, if ever. And then years after that, they start getting mouth sores. And then one time they have pleurisy. Eventually, they have to have multiple different things that happen to them over and over and over again. And they also have to have a certain amount of antibodies before they can be diagnosed, or before a rheumatologist even will diagnose them with lupus. Now, one of the issues with that, unfortunately, is that they could also already have kidney damage by the time they're diagnosed and given any type of corticosteroids, prednisone, things like that to try to calm down the effects of the immune system on that person's body. Now, one of the things that they're going to be tested for is they're going to be tested for ANA. And ANA stands for anti-nuclear antibodies. There's only about 5% of patients or less that test negative for ANA and still have lupus. So what that means is 95% or more of the patients who test positive for ANA are probably going to have lupus. So this is just showing you a little bit of that MALAR or butterfly rash, and then mouth sores, muscle aches, inflammation of the pericardium, poor circulation. A lot of times people who have lupus also have Raynauds, and this is another butterfly looking rash or a MALAR rash. These are the discoid rashes, so you can see they're more rounded. Another look at discoid rashes. So these complexes, they can cause inflammation by activating neutrophils and monocytes. They also make blood vessels leaky, and those neutrophils and monocytes, they can release prostaglandins and other enzymes that can dissolve tissues. Those immune complexes can also, like we talked about, activate clotting factors, and you can get tiny blood clots in the system. Some of the outcomes would be the vasculitis and arthritis, and then glomerulonephritis is inflammation in the nephrons of the kidney. So type III immune complex allergic disorders, these are mediated by insoluble antigen-antibody complexes, but they activate complement. Okay, so activation of complement, that generates those chemotactic agents, and those chemotactic agents can call up helper T cells, cytotoxic T cells, but it also activates vasoactive mediators like histamine, for instance. And then you have that alteration in blood flow again, vascular permeability, inflammation, and so on. So the immune complexes, they're formed in the circulation, and they can attach to the blood vessel linings, deposit in tissues, and then they elicit that inflammation. Now, inflammation, that edema can actually lead to death of the tissues. So one of the leading causes, for instance, of cardiovascular disease is inflammation. Now, it's really kind of interesting. We talk about this more in my nutrition class, but eating too much sugar, eating too many carbohydrates causes an inflammatory response. Also, low levels of vitamin D help to lead to an inflammatory response. And we see people who have autoimmune disorders, and they typically have very low levels of vitamin D, very high consumption of sugar, and typically very high stress levels in their lives. So that might tell you something about how to prevent autoimmune diseases, as well as cardiovascular diseases and a number of other diseases. So this is an immune complex, and all these little black dots here are actually macrophage flying around, and this right here is the outline of the blood vessel, and the fact that it looks like this shows you that there's tons of inflammation here, and this is leading to vasculitis. So complement is made out of proteins, and we call them C proteins, and we give them numbers of C1 through C9, and different complement proteins can do different things, like C3b promotes phagocytosis, C3a and C3-5 increases permeability of blood vessels. C5a increases chemotactic agents, or so that neutrophils and monocytes can bind to cells. C5 through C9 increases cytolysis, which means that it opens up that kind of donut we talked about on the cell membrane so that the cell goes through lysis. All right, so here's KERRY again. KERRY does not make it to the rheumatologist. She has a seizure. As she is leaving her primary care physician's office, she is quickly rushed to the emergency department where her primary care physician relates her medical history and recent test results. The emergency department physician calls in the rheumatologist on staff at the hospital for consultation. Based on the symptoms and test results, the rheumatologist suspects that KERRY has lupus and orders a pair of blood tests, an anti-nuclear antibody test to look for antibodies that bind to DNA, and another test that looks for antibodies that bind to a self-antigen called the Smith antigen. Based on the blood test ordered, what type of reaction does the rheumatologist suspect is causing KERRY's seizure? Can you figure this out? Type IV hypersensitivity. So type 4 is very different from the other types. It's a T lymphocyte reaction. The others have mainly B lymphocyte reactions, and we're looking at antibodies in those. It doesn't depend on antibodies for this one. And the clinical appearance of the reaction is delayed a few days even. Can be delayed as much as a week after contact with the antigen. So it's a slower process. That's why we call it delayed. So antigens are captured by macrophage for presentation to T lymphocytes. And these T lymphocytes react only to the antigen, okay? And they're sensitized to become cytotoxic T cells and memory T cells. So the cytotoxic T cells attach antigen and cause inflammation, or they can create a cytotoxic reaction, which means that those T cells also can cause lysis of the cell. Helper T cells orchestrate the attack against different intracellular bacterium such as tuberculosis, leprosy, and they can also cause dermatitis by creating immune complexes. And they can also cause transplant failure. So type 4 reactions are characterized by accumulation of macrophage around an antigen, and they form a nodule of lymphocytes and macrophage. And these nodules are called granulomas. And we see these in tuberculosis, okay? And so the Mantoux TB test also is a granuloma. That's what you're looking for, okay? Cytotoxicity is the mode of type 4 hypersensitivity that is important in tissue transplant rejection. Most common type of type 4 reaction is dermatitis. So you have contact dermatitis, tuberculosis, transplant rejections that are going on with this. So I thought this one was very interesting. Somebody actually took a pin and they have contact dermatitis, so they drew on themselves. This is also contact dermatitis. So delayed hypersensitivity is where you have the CD4 cells. They're releasing cytokines, which then cause inflammation and long-term tissue injury. And then these are granulomas. And then right here, just stained differently so that you can see the macrophage and the cytotoxic T cells in this area, along with helper T cells. So with the Mantoux test, okay, where you're testing for tuberculosis, you're testing to see if the patient was previously exposed to TB. So you inject inactive TB antigens into their skin, and now they have these memory cells. And so you're going to have the delayed hypersensitivity reaction, so you have to wait for a couple of days, come back and they read your test to see if you have a granuloma in the area. So type 1, basically allergies and using IgE, mast cells. And then type 2, these are antibodies that are activating. Type 3, you have the immune complexes. And type 4, you have the delayed hypersensitivity, which uses helper T cells and cytotoxic T cells. And here's just another chart that you can take a look at on your own time. By the way, the delayed type with the granulomas, you can also have macrophage that sometimes fuse, and then you get what are called giant cells. And those then, what you can tell when you're looking under the microscope that you have these giant cells. And so that's what you're looking at here. These are macrophages that have actually fused. So they call it a giant cell granuloma. And again, this is a granuloma right here. All these little black dots, these are all macrophage. All right, well, that is the end of this lecture. See you next time. Bye.